Well, good evening. It's a pleasure to be here. I actually wish I was physically there because I've enjoyed my visits to your wonderful country. I want to thank Professor Aziz Belal for asking me to give just a brief kind of description of some treatments for dizziness. But basically, I'm going to concentrate on a little bit of the history of some of the procedures that we have done and developed over the years. First of all, I think we have to realize that we are talking about various types of dizziness that can be amenable to surgical treatment. But first of all, in the evaluation, we have to determine what the diagnosis is. For instance, is it BPPV, or is it Meniere's disease, or vestibular neuritis? Multiple causes of dizziness. And then we have to evaluate what is the function of the inner ear on this particular patient. Do they have a reduced response? We want to make sure that we're not dealing with a central problem, because no amount of surgery is going to help that. So it's always important when we're evaluating the patients to get a hearing test. So all of our patients who come in, even if they're complaining of dizziness, will receive an audiogram just to better ascertain the function of the inner ear. So if we're looking at a Meniere's patient, typically they will tell you, or you can ask them, do they get a fullness or pressure in their ear? Does the tinnitus get louder? Is there anything that can be an aggravating factor? Just as a little thing that we see so many of patients with Meniere's disease, and so I'm going to focus more on the Meniere's disease because we see quite a few. This is a 1-month survey we did where you can see we saw 11 new patients with a complaint of Meniere's disease, and about 68% of the patients that came back in that particular month had were diagnosed with Meniere's disease. Medical treatment, again, we will treat the patients medically. Obviously, you're going to go conservative at first. Such things as low-salt diet, beta-histine we've been using for the past several years. By the way, interestingly enough, it's not approved in the United States. So we have to have it specially compounded. And many of our patients who are on long course beta-histine will send for it, typically from Canada, and it'll be mailed in. Allergies can be an important part of Meniere's. In a big study that we did many years ago, we found about 18% of the patients with Meniere's disease had aggravating factors of allergy. But let's go ahead and talk a little bit about surgery for Meniere's disease, or for dizziness really, because we're talking about different diseases. For example, Meniere's disease of vestibular neuritis. Some patients will have a recurrent vestibular neuritis with severe episodes of vertigo, but no effect on the hearing. That may be a cochlear eye drops, or it can be just recurrent vestibular neuritis. And some patients have chronic unsteadiness after that, and sometimes just sectioning the vestibular nerve will help that problem. But these are a few other things that we're talking about can cause patients who have dizziness. And we talked about medical treatment, and then let's get into the surgery because we're talking about medical failures now. Many of you know about the endolymphatic shunt procedure. That was actually first described by George Portman in 1928, but nothing ever came of it. He reported some good results with doing a decompression or endolymphatic sac procedure. Bill House, then in the late 50s, modified his procedure to do an endolymphatic subarachnoid shunt, placing a tube from the endolymphatic sac into the subarachnoid space. As time went on, we actually changed that into just doing a endolymphatic mastoid shunt, which seemed to have the similar results. I'm going to also talk about other procedures like cochleosacculotomy, which I'm sure none of you have ever heard of, and of course you can do a labyrinthectomy. So medical failures then, one of the procedures that I like, and we've done over the years, is a retrolabyrinthine selective section of the vestibular nerve. The reason I like that procedure, and I'll get into a little bit more, but about 95% of patients who have severe episodic incapacitating vertigo will do very well with a retrolab nerve section. The results, about 95% will get total relief. And the good news, it rarely affects the hearing. About 5% of the patients do have some issue with hearing loss after the surgery. We also then talk about labyrinthectomy. I like to avoid that if I can. And the reason is that somewhere down the line the patient may develop a problem in the other ear, that the patient's continuing to have episodic vertigo, not controlled with medicine, and the hearing's good, and also if the vestibular function is good, because I don't want to cut a balanced nerve in a patient with excellent vestibular function, because they're going to have a great deal of difficulty with the vertigo. So the endolymphatic shunt is good because it's an outpatient surgery. The patient goes home the same day, takes about an hour, maybe an hour and a half at the most, and the morbidity or any issues post-operatively are very minimal. And we'll talk a little bit about what the results are with that, but it's not perfect, but considering it's relatively non-invasive. If that fails, or the patient has very poor hearing and a significant reduced response on VNG, I do like the retrolab nerve section. Mentions also middle fossa. I think Bill House was one of his original indications for doing the middle fossa was because of vertigo, to cut the vestibular, selectively cut the vestibular nerve. So this is the endolymphatic shunt procedure. It's just a mastoidectomy, going in and opening the endolymphatic sac, and then placing a little silastic sheeting, cutting in the like a T, and then fold it over on itself. And this just shows the video of it, or the photograph. So these are the results, and interestingly, this is when we were looking to compare, do we need to do the endolymphatic subarachnoid shunt, or would the patients do just as well with the endolymphatic mastoid shunt? And as you can see, probably about 75% of the patients showed complete or substantial relief of their symptoms. 22% or 23%, 25% had insignificant results. Very rare where the patients ever get worse. So it's a good procedure. It's not 100%, as I said, but it is an outpatient procedure. And we asked the patients whether they were pleased with the results. As you can see, the majority of the patients were happy with the results. And as far as complications are concerned, very minimal, as you can see here. Dead ears, we did have 2 patients, or 1%, had a dead ear following the procedure. The vestibular nerve section, I've already mentioned middle fossa and retrolabyrinthine, and also some neurosurgeons would much prefer to go retrosigmoid, and that works as well as the retrolab. We like the retrolabyrinthine because we're pretty much extradural, except when we just get in, open the sinusoidal angle, identify the cochlear, vestibular, and facial nerves, and section the vestibular nerve only. Again, this just shows the procedure, but this is what it looks like. We've gotten behind we like to get behind the sigmoid, particularly if it's forward, because we need to retract it posteriorly in order to get the exposure of the cerebellar pontine angle, identify the cochlear nerve and the vestibular nerve. And there's a pretty good plane between the nerves. This is the cochlear nerve, and this is the vestibular nerve. So you can see that they actually do look completely different. And again, here we have now sectioned the vestibular nerve. Here's the cochlear nerve, still intact, and we have gone in now and just sectioned the vestibular nerve. And again, this shows how we've separated the vestibular. This is the facial nerve, and then we have just next to that the cochlear nerve, and then we have the vestibular portion of the 8th nerve. So we're going to separate those and section them like so. And again, I've already showed that. So substantial relief, this particular study, in 93% of the patients had substantial relief. The majority of the patients were able to go back to their normal activities. and 2% had complete sensory neural hearing loss. So a relatively safe procedure. I'm going to mention gentamicin infusion. That does work. There are some advantages to it, and there are some disadvantages. The advantage is non-surgical. It does control vertigo, I would say maybe 80%. But the problem, and what I have trouble with, is that you don't really know where you are. You've given a little bit of medicine. Now what's going to happen? Are they going to have more attacks? If they do, you better give them some more. When do you stop? And some patients end up with chronic unsteadiness, which is actually can be a problem. And some patients actually will lose their hearing. I had one patient who is actually a physician. He had Meniere's in his other ear and profound loss, then developed episodic vertigo and in that ear, and I recommended we do a retrolab nerve section, but he chose to have gentamicin, and he lost all his hearing in that ear and then was unsteady. Ultimately, interesting enough, he developed Meniere's in the other ear, and then he had problems hearing. So I ended up doing a cochlear implant on the gentamicin ear, and it worked quite well. And then this is the patient that was mentioned to you that ended up with a cochlear implant. Destructive procedures include transcanal extended oval window labyrinthectomy, a post-auricular labyrinthectomy, and then sometimes going a little bit further and actually do the labyrinthectomy and then section the vestibular nerve. Transcanal labyrinthectomy, we call it an extended one because we're going to drill out the oval window all the way down to the round window, and then we're going to be able to get hooks in and actually get the ampulated ends of the three canals, because if you leave them, they could end up with some further activity. How about something you probably never heard of, and that is a FIC procedure or a Cody tack or a cochleosacculotomy. And these were all, when I was just getting started back in the 70s, these were proposed procedures. So this is a FIC procedure, was taking a sharp needle and penetrating through the foot plate of the stapes into the vestibule and puncturing the saccule. Or then Cody, Dr. Cody recommended, well, that's a good idea. Let's just put a tack on the foot plate. So as the saccule dilates, it'll hit that tack and it'll decompress again, and that will eliminate the symptoms. Obviously, I've never done that particular procedure. I did do a FIC procedure or two, didn't find it particularly advantageous. But another procedure we used to do in more older patients, and that would be a cochleosacculotomy. It was popularized. If a patient had poor hearing and good vestibular function, we don't want to do a labyrinthectomy because then they become disabled. We probably don't want to do a retrolab nerve section in an older patient. So we can do this procedure where we expose the round window and the stapes and place a hook through the round window into the vestibule, and then I remember you would tilt the hook a little bit and you would actually see the foot plate move. So you knew you were in there to do basically destroying the saccule. And interesting enough, patients did not have a lot of vertigo. In fact, we used to do this in outpatient, and it did help their vertigo. So it's actually a good procedure, but I haven't seen it done or done it myself for many, many years. So that's kind of a brief description of some things we've done in the past. I wish I was there to get questions, but you can always email me at jhouse@houseclinic.com. So again, Professor Aziz Belal, thank you very much, and I hope to see you all next year.
Hello, my name is Dr. Kevin Peng, neurologist here at the House Institute. Thank you for watching this video. The House Institute provides free educational videos for hearing health professionals worldwide. To help support videos like these and other educational efforts, please consider donating by clicking the link in the description box below. Your generous support allows us to keep videos like these at no cost for you and others. Thank you.